Hospital. Here you can see our team, it's surgeons and anesthesiologists and our cardiosurgeon. So our case report. A 24-year-old healthy pregnant woman with more than 32 gestational weeks was admitted to the perinatal hospital due to the fetal hydrops and preterm labor at the 32 week of fetal gestation. So this baby, birth weight 3,400, height 22 centimeter, and Apgar 2.4. Information about prenatal examination is very poor, and we just didn't know what they find on pathology. The child was born with symptoms of respiratory and heart failure. The mechanical ventilation was started to correct respiratory disorders. And the mechanical ventilation was started very quick. Further treatment was in the neonatal intensive care unit. From the first minutes of life, the newborn received respiratory cardio support. A chest X-ray was performed immediately and showed the presence of bilateral pleural effusion, clinically significant. Pleural puncture and drainage have performed very quick. On the second day of life, according to the data of heart sonography, a formation was found in the pericardial cavity. The size of tumor was 25 millimeters, and it was compressed the right part of heart. As a result, the cardiac muscle ejection function decreased. In addition, the child developed a clinical picture of increasing renal failure, so peritoneal dialysis was started. On the fourth day, we did pericardial puncture. The newborn was diagnosed with pericarditis, and pericardiocentesis was done. And on the 9th day, the ultrasound showed that tumor grows up. And after that, it was decided to transfer the child to our hospital for diagnostic and treatment. This CT scan was made in our hospital. The large solid formation. So computer tomography showed that this large formation on the chest, located in the mediastinum, or maybe inside pericardium, are regularly rounded with clear contours, size 33, 24, 21 millimeters, and it compresses and dislocates on the right lung and right parts of heart. But if we talk about CT scan, it was not very clear about localization. And laboratory findings, it was nothing so impressive. Inflammatory factors were not expressed, and even alpha-fetoprotein not so high. Let me remind you that for newborns in the first 2 weeks of life, alpha-fetoprotein numbers can reach 35,000–40,000. So, well, in first 2 weeks of life, our patient has already received this treatment. It was drainage of the pleural cavity, pericardial puncture, peritoneal dialysis. After all this, I would like to say the child has become stable, but unfortunately the main problem has not yet been removed, and we have only seen the deterioration and growing of a mass of tumor. So finally, after hard work of our intensive care team, we were decided that the early surgical treatment was necessary. The decision to operate was made on day 19 of life. Surgery team was including the neonatal surgeon, pediatric cardiac surgeon, neonatal anesthesiologist, and the great nurse and assistants. The baby underwent median sternotomy, excision of the tumor, and no blood was lost. After surgery, baby was returned in neonatal ICU. So here it's a photo of our surgery. After entry into the pericardium, here it's a pericardium. You can see the tumor. The section around the large teratoma was without technical problems. And after, we can see how it was well encapsulated. Here is very good capsule. And the tumor was located between the aorta and left pulmonary artery on a round side, around 20 millimeters in diameter. It was removed by using a coagulator. Here is a short video about our surgery, very delicate technique. The lesion is completely was removed. But you can see how we are a little bit slowly, but we need this delicate moment. So our clinical pathology demonstrated grade 2 immature teratom. In post-operative period has had no complications. There was a positive trend, the regression of cardiorespiratory disorders. The discharge of fluid through the pleural drain stopped after 3 days, and drains were removed on the 7th. Cardiotonic support was cancelled after 7 days. He was soon extubated on 10 days. And we start to feed this baby on 11th day. So our patient got well quickly. So here we want to say you about control test of alpha-fetoprotein. Control test of alpha-fetoprotein showed a steady decrease. So this was before surgery. It was after surgery, and 1 more month after surgery, we check it again. We always see how it's decreased. We also did a consultation with oncologist, and after second analysis for alpha-fetoprotein, there are no indications for chemotherapy. So it's outcomes. Here our baby. He's just 10 days after surgery. And this picture from mother, she sent it after 2 months. He was growing very well. And here we would like to tell you a little bit about teratom. Teratom is a type of germ cell tumor that may contain several different types of tissue, such as hair, muscle, and bone. Teratoms may be mature or immature. It's really not often tumor in our practice, just frequency 1 for 40,000 of newborns. So the most famous type and more often found is sacrocagular teratom, 40–60% in different publications. And very difficult for management, and it's really not easy to treatment this type. It's cranial and epignatous. Also, the very famous type of teratom is ovarian, but the most uncommon type is intrapericardial teratom. However, you can see it's already around 100 cases reports in literature. So intrapericardial teratoms are germ cells tumors predominantly found in newborns and infants. They typically consist of all 3 germ layers, but can contain fewer, and the tissues can range from mature to grade 3 immature. Teratom has multicystic structure. They are typically encapsulated with a vascular stalk arising from the aorta of pulmonary artery, with the mass anterior to the heart with compression of the right atrium and ventricle. Large size of tumor. Pericardial effusion, and a lot of cases of babies with intrapericardial include hydrops. What's so important to know about is high risk of cardiac tamponade and airway obstruction. So, well, in this discussion, we want to talk about diagnostic of rare tumor in the prenatal and postnatal period, and method or tactic of the surgery treatment, and impact of complications on the prognosis and management, multidisciplinary approach, and the importance of the control of alpha-fetoprotein. So infants are now often diagnosed in utero during screening ultrasound. The tumor may be associated with hydrops and pericardial effusion. Normally, it's possible to discover on 2nd trimester, and it makes possibility to planning next step of treatment and manage it more effectively. After birth symptoms are determined by the size of the teratoma and the presence of pericardial effusion that can result in mass effect and or tamponade. Imaging after birth should include echocardiography to find the size and characteristic of the tumor and effusion, cardiac function, and mass effect. Consistent findings on CT scan, a combination of fatty tissues and calcification in the mass. So here we would like to talk a little bit about methods and tactics. So when hydrops is present, treatment depends on gestational age, and the management is to be preferred when lung maturity is assured. But in actual time, treatment of neonates and infants with intrapericardial teratom has greatly improved as technology and research have advanced. There are some publications which show successful results of the fetal technique. The aim of the in-utero intervention is to avoid intrauterine demise due to cardiac tamponade and hydrops through prolonged pregnancy until lung maturity can be induced, prevent pulmonary hyperplasia, and make facility neonatal stabilization and intubation. The most frequently used antenatal intervention is pericardiocentesis. While this procedure appears safe, repeated drainages will often be necessary, what grows the risk for iatrogenic preterm delivery. The placement of a pericardial amniotic shunt provides an alternative treatment option through which prolonged drainage of the pericardial fluid, and it could be obtained using a single percutaneous procedure. So also there were reported few cases with very successful case with exit. It's when cardiac tumor when ex-uterine intraperitoneal treatment. And then finally, we should say that only postnatal surgery and complete resection is the only curative and life-saving therapy. Here is the example of different publications about exit procedure and shunting. You can easily find it. Impact of complications on the prognosis and management. There is correlation between hydrops and prognosis. If we do treatment of all complications, draining of hydrothorax, pericardiocentesis, hydrops treatment, we can increase a chance for more effective surgery, reduce the time in neonatal ICU, and speed up recovery. Also, what we want to show you, how it's important to use multidisciplinary approach. We all understand how it's important for this case. Good communication and organization of collaboration between different doctors is a way for successful treatment, because our team has a very different specialized. And again, we want to remind about control of alpha-fetoprotein. It's a good instrument to monitor relapse and check the fluid recovery. But we must remember about high level of alpha-fetoprotein for newborns. Elevation of alpha-fetoprotein levels alone does not allow for the diagnosis of malignancy. And in conclusion, collaboration between different specialists and multidisciplinary approach is the key to successful treatment for newborn with intrapericardial teratom. Good treatment of complications and early excision of the tumor can improve the prognosis. High quality of prenatal diagnostic can be overestimated. And we need to collect all experience of management of different rare cases of tumors of newborns and share it to save one more life. So, well, thank you so much for your attention.